So we spoke a lot about like right to left shunts, but now let's see like how we would what would present as like a left to right shunt. And thinking about left to right shunts, right, left to right, which meaning it's going from the left atrioventricle into the right atrioventricle. It's obviously you're not going to have the at least initially, you're not going to have the oxygen problems or the cyanosis. So these are classified as acyanotic at presentation, which means that initially there's no problem with oxygenation, and that's why a lot of times these are more difficult to diagnose, or at least diagnosed much later, right? But because of something we'll talk about later called Eisenmengers, it can lead to cyanosis down the road for these babies. So frequency of these shunts is the VSD is obviously the most common, then the ASD, and then the patent ductal arteriosus. So VSD is ventricular septal defect is the most common of these. And let's jump right in. So VSD, right, ventricular septal defect. Again, because it's shunting blood, from the left side to the right side, you're going to be asymptomatic at birth. Okay. There's a higher oxygen saturation in the right ventricle, and the presentation could vary here a lot. It could happen, it could manifest itself weeks after birth, and it could remain asymptomatic throughout life. But again, VSD could either present symptomatic or asymptomatically. Obviously, a large VSD will be noticed. And that's because, it'll lead to overload of the left ventricle and obviously left-sided heart failure. So large VSDs obviously will lead to heart failure and will be noticed. But it's also important to note is that a lot of them will just self-resolve, because remember, the muscular is greater than the membranous flow. So you're going to have a lot of these will just self-resolve. Okay, so VSD is really straightforward, but it is the most common one. Is the most common cause of left to right heart shunting, and therefore they do test it quite a bit. ASD, atrioseptal defect. So here you're going to have the left atria is going to be shunted to the right atria. So obviously it's a left to right shunt. Again, may present initially without any cyanosis, and may go undetected because of that. Very important to note, and this is why, this is sort of how they can really test this and give it to you in the stem, is they can tell you there was a wide fixed split S2. So if you ever hear the word wide fixed split of the S2, that's going to be your ASD, like without a doubt. And it's almost pathognomonic for ASD. And it's important to understand what happened on an embryologic level, as has sort of been our trend here, to touch base on what happened that led to this defect. And obviously the exam likes to go after this. So here, the ostium secundum, pretty much, it's either ostium secundum or ostium premium. But it was a defect in this. Usually it's actually going to be ostium secundum. That's actually the most common one. Ostium premium defects are less common, although it could happen in Down syndrome. But it's a defect of the ostium premium or ostium secundum to form. And obviously symptoms are going to be ranging widely from none to obviously floor heart failure. And because there's a left to right shunt, it is a source of paradoxical emboli. So later these patients could present with like a showering of emboli or septic emboli from a paradoxical from the left to the right side, and the answer could be just because of ASD. Also, you'll see this in PFO and a patent foraminal valve, but there's like unused tissue, versus ASD is actually like there's an absence of tissue. In PFO, it's just it was unused. Right here, there was a defect. Right, obviously it's a heart defect. So oxygen saturation increase in the right atria, right ventricle, and pulmonary arteries. So you're going to have there, but essentially this may not present with any cyanosis. Initially, later, obviously there could be, but in the beginning there won't be, and therefore sometimes the diagnosis is delayed. Okay, so just understand with ASD how there's this left to right defect, which leads to a wide fixed split S2 sound of the heart. PDA, patent ductus arteriosus. So obviously we spoke about the ductus arteriosus, but here it remains patent. So you could see the connection between the aorta and the left pulmonary artery. Obviously it's supposed to close, but here it remains patent. So you're going to have this connection of blood from the aorta to the left pulmonary artery. So obviously in the fetal period, right to left shunt is normal, because remember, you're trying to bypass the lungs in the fetus, in the newborn. But obviously it's not normal in anything past the newborn stage. So again, in the neonatal period, there's going to be decreased pulmonary vascular resistance, leading to the left to right shunt and right ventricular hypertrophy, and possibly even left ventricular hypertrophy and heart failure, right? So obviously it normally closes after birth, and in adults, and if this is left open in children and adults, it will make a continuous machine-like murmur, and that is so pathognomonic and such a good buzzword. They love putting this on the exam. But so really just recognize, if they ever give you a description of heart murmur, which is machine-like and continuous, you have to think of PDA. You have to. You can maintain patency by prostaglandins and low oxygen tension. And obviously uncorrected patent ductus arteriosus is going to lead to late cyanosis in the lower extremities, and obviously a difference in cyanosis between the upper and lower extremities. So you will see a later cyanosis, especially in the lower extremities, if it's uncorrected. Okay, so understand, like, obviously, while it's normal to be patent in the fetal period, once the baby's born in the childhood setting, it's not a normal thing, and it leads to this continuous machine-like murmur.